Saumyta,
A
go on.
very good evening. Today I am starting with CA larynx case presentation. My patient, 52-year gentleman, resident of Samastipur, farmer by occupation, presenting with the chief complaint of सर क्लास ज्वाइन करने के लिए हाँ यस सर change in voice for 3 months, difficulty in breathing at rest for 2 months, and cough on taking meal, on liquid diet on and off for 1 month, and pain in the left ear for 10 days. As noted by the patient, he was apparently alright 3 months back when he noticed a change in voice which was insidious in onset, rapidly progressive, hoarse in nature, and persistent throughout the day, and worsened over last 15 days. He also gives the history of difficulty breathing, rapidly progressed to noisy breathing in 15 days, and patient presented to us, then underwent emergency tracheostomy. History of intermittent cough with liquid started a month back, and history of intermittent pain in the left ear since 10 days, insidious in onset, relief partly on medication, and not associated with diurnal variation or any relieving and aggravating factors. So, no history of any excessive salivation or foul smelling discharge from the mouth, and there is no history of any difficulty speaking and chewing, and dysphagia and odynophagia. No history of any vocal abuse, and no history of cough with expectoration associated with fever, and no history of any other lesion in the oral cavity or any mass in the neck. So,
Saumyta,
yes, sir.
जस्ट एन इनपुट ये हिस्ट्री ऑफ डिस्फेजिया और ओडाइनोफेजिया नहीं होगा, या तो हिस्ट्री सजेस्टिव ऑफ डिस्फेजिया और ओडाइनोफेजिया और हिस्ट्री ऑफ डिफिकल्टी इन swallowing और पेन ऑन swallowing. Okay,
Okay, sir. Suggestive of.
getting my point. Either history suggestive, see, dysphagia or odainophagia are medical terminologies, right?
Yes, sir.
So if you are mentioning dysphagia or odainophagia, mention that there is no history suggestive of dysphagia or odainophagia, or plain and simple say there was no history of difficulty in swallowing or pain on swallowing.
Okay, sir.
What is the significance of this history?
Sir, if oropharyngeal or hypopharynx is involved, then patient can have swallowing difficulty.
Swallowing difficulty and why odainophagia?
In oropharynx, sir, patient have because of advanced disease, patient have involvement of nerves, glossopharyngeal nerve, and deep-seated disease.
Saumyta, two questions. Like, did you say hoarseness of voice or just hoarseness?
Sir, change in voice which is hoarse in nature.
Change in voice which is hoarse in nature. But simply you can say that like he is complaining of hoarseness, okay, or change in voice.
Saumyta, you mentioned. Sorry, you go on, Dr. Kunal.
Yeah, and one more thing you told, no, like if a patient is having pain while swallowing, it means that it is only involvement of oropharynx. Does the patient will also complain of pain if the disease is in the hypopharynx?
Yes, sir. Pain.
Or in case of supraglottis only, maybe?
Supraglottis, sir, usually patient don't have a...
No, supraglottis, one of the main symptoms of the sign is that the patient will complain that he is having throat pain. And what is the significance of like saying that the patient is having hoarseness, then he is having pain? What does this signify?
Sir, disease arising from glottic region and then progressive upward.
Yes, that can be.
So, upwards by what structure exactly is involved which leads to pain? Which is the most mobile structure in the supraglottis which can cause pain?
Aryepiglottic fold, sir. False vocal cord.
So if the disease involves arytenoid cartilage, okay, that is most important factor for pain.
Okay.
Other thing you said that there is change of voice, mostly hoarse, something like that, right?
Yes, sir.
What are the other changes in voice which can be there?
Sir, hot potato voice and
See,
pitch, changing in the pitch of thinning, matlab, high pitch and low pitch sounds.
so you should read about roughness, breathiness, asthenia. Okay. These are some of the factors, some of the quality assessment of voice. Okay.
Okay, sir.
So it is called breathy voice when there is glottal air escape. There is weak voice when the chords are spasmodic.
Okay, sir.
Okay, that is called as asthenic voice. Okay.
That will be in
Hoarseness.
myasthenia gravis.
There is harshness of voice when the ये तुम्हारा जो हिरानोस cover body होता है, there is a problem in its gliding, then it leads to a harsh voice. Hoarseness is basically a combination of a hoarse voice can be breathy, harsh, or asthenic, anything.
Okay, sir.
Getting the point?
Okay, sir. The patient won't say, na sir, कि patient is having, मतलब patient will say कि there is a change in voice.
Patient will say change in voice, or you can say hoarseness. Plain and simple hoarseness. Hoarseness means change in voice.
Okay.
Hoarseness is an English word. It means change in voice.
Okay.
मेरा गला खराब है hoarseness.
Okay, sir. After visiting to our OPD, patient was in stridor. Patient underwent emergency tracheostomy and imaging and follow up with workup. No significant family history.
So does patient have any complaint of any neck swelling?
No, sir.
Did you mention that?
Yes, sir.
You mentioned that. Okay.
An history of your tobacco use, smoking?
No history of tobacco consumption. History of tobacco consumption in the form of canny since 2 years, and abstinence since 3 months, and no history of any smoking and no history of any alcohol intakes.
So Saumyta, then like you are saying, there is no history of smoking or chewing and other thing, alcohol intake and all. So he's having a negative history. So what can be the reasons for this hoarseness? What are the other conditions which can lead to the person having hoarse voice, with hoarse change in the voice?
Such change in the voice can be due to any benign pathology in the vocal cord or thyroid gland also, and if patient has have advanced lung disease or esophageal cancer. But since the patient patient is giving hoarseness first followed by difficulty in breathing, so most probably etiology arising from the laryngeal.
Apart from
So we are mixing two things, Saumyta. You are not saying about etiology. What sir is asking is etiology of the disease. You have said that the patient does not have any history of alcohol intake, no history of tobacco intake. Then he is asking what is the probable etiology for this disease. And there is a very important history which you have missed for this.
Vocal abuse.
Vocal abuse is usually not associated with carcinogenesis. Anything else that you are aware of?
HPV is one of the risk factor in GERD, sir.
GERD is a very important risk factor. So did you rule out GERD in your history?
Sir, no medical comorbidities. In that only it's included because
GERD is not a comorbidity. GERD is not a comorbidity. What are comorbidities?
Diabetes, hypertension, and his past treatment history, sir.
Sorry, continue.
Yes, Saumyta, like as you mentioned, no, like patient is having no history of hypertension, no history of kidney disease and other thing. Why these histories are important? Why the history of comorbidity is important in case of a maybe your laryngeal or hypopharyngeal cancer?
So pulmonary function itself is important to take decision for the treatment.
Okay, right.
And
Very right.
hypertension and diabetes, we are treat just for patient should be optimized before taking any treatment.
Okay, and one also like your kidney disease and all, like you have to see whether creatinine level and the straight answer is that it will aid in your decision making, like deciding the modality and other things. Okay.
Okay, sir.
So go on.
Sir, no previous any surgical illness. He's recently diagnosed. Yes. Hello.
चलो
Recently
Chest.
diagnosed.
ठीक है.
Sir, should I proceed?
Yeah, please.
Recently diagnosed hypertension on medication since 2 months. Patient has good appetite, undisturbed sleep. Patient consume mixed diet. Bladder bowel habit normal and married with 3 children. To summarize, 52-year-old gentleman, farmer by occupation, with chronic tobacco consumption, presenting with the change in voice, with intermittent cough on liquid diet, with stridor with radiating to left ear pain, suggestive of lesion arising from glottis, rapidly progressive disease, most probably a malignancy in the larynx.
Okay, Saumyta, then like how will you proceed in this case? Like, what will be your next step of
examination,
like, management?
sir, for this patient? Examination.
Okay, go on.
I examined my patient with a well-lit room with proper informed verbal consent in presence of a male attendant. Patient is conscious, cooperative, averagely built and nourished, well-oriented to time-place person. Patient vitally stable, ECOG 1, BMI 22.9 kg per meter square, no pallor, icterus cyanosis, clubbing and generalized lymphadenopathy. Local lymphadenopathy I will be discussing in my local examination. On inspection of oral cavity, mouth opening is adequate, oral hygiene is maintained, no loose teeth, and no other lesion in the oral cavity like submucous fibrosis and erosions, and movement of tongue is normal, no protrusion and deviation. On fiber optic laryngoscopy, base of tongue is free, pellicula is free, lingual surface of epiglottis is also free. So lesion arising from starting from laryngeal surface of the epiglottis is involved. Also proliferative growth of the involving left true vocal cord, left false vocal cord up to anterior commissure, and left true vocal cord is fixed and right vocal cord is normal. Left glottic extension and extending to supraglottis and extending to subglottic region. No lesion in the hypopharynx and oropharynx. These are the images in which we can see it is in inner surface of the epiglottis and aryepiglottic fold is free and bilateral piriform sinuses are uh, have no disease. And patient is able to extend neck and there is one dilated vein, no any sinuses and redness or inflammation in the skin, and there's a
Why did you take this, Saumyta? Why did you take this, Saumyta?
Yes, sir.
Why did you take this history of your patient is able to extend his neck? What does it signify?
Because if prevertebral fascia is involved, patient will not be able to extend neck.
So, like if there is no extension of neck, then it suggests that disease might be very advanced. Or extensive disease. So, like it has gone behind, have involved, as you told, your prevertebral fascia muscles and other things. So that part is important.
And laryngeal crepitus is present. One bulge of lymph node in the left level 2 level, which patient has not noticed, but in examination along one single 2 centimeter lymph node in the level 2 palpable mobile.
Voice
Voice.
Hello.
Yes, sir. Tracheostomy. After tracheostomy, I have asked after history after tracheostomy while closing the tracheostomy tube.
You are not audible properly. Hello.
Hello, sir.
Yes, I
Hello.
think there's some network issue.
Okay. Hello, sir. Hello, sir. Hello, sir. Am I audible?
Yeah. Dr. Kunal?
Sir is saying network issue.
Hello. Yes, Saumyta, you are not audible. Go on.
Visible widening at the larynx, laryngeal cavities present, bulge in the left neck at the level 2, single solitary mobile neck node palpable at the level 2, and the movement of neck appears to be normal. Systemic examination normal.
Dr. Saumyta, how
Yeah.
do we check crepitus, laryngeal crepitus?
Sir, at the level of cricoid level, we are moving in horizontal plane. Full.
And what do we look for?
Sir, prevertebral fascia is involved, then there will be crepitus will be absent. The movement of cricoid over the vertebral body.
Yes, very good.
So to summarize, 54-year gentleman, farmer by occupation, chronic tobacco consumption, presented with the hoarseness of voice with intermittent cough on liquid, associated with the left radiating ear pain. On laryngoscopy, ulceroproliferative growth in the left vocal cord extending to supraglottic rapidly progressive symptoms with isolated neck node at the level 2. So provisional diagnosis is CA larynx, stage CT3 and 1. To confirm the radiological diagnosis, radioclinical neurological stage, I would like to do CCT of neck and thorax.
So, Saumyta, like you mentioned about the fiber optic examination, no?
Yes, sir.
Like you did it.
Yes.
So, what kind of examination you will prefer? It's direct, direct laryngoscopy, indirect laryngoscopy, or
Sir,
your fiber optic examination? What are the advantages of each other over?
So in fiber optic laryngoscopy, GA can be avoided and patient can be done in the OPD basis. But very crucial structures like anterior commissure and postcricoid region or apex of piriform sinus, hidden areas can be difficult to see in that, but in direct laryngoscopy general anesthesia is required, and for decision making before a patient taking for any decision in the operation theater, we should do direct laryngoscopy before any procedure.
Okay. And like you as you have mentioned about the fiber optic, so it is of two types. One is your rigid fiber optic, other is flexible. Which one you prefer?
Sir, we usually do flexible fiber optic laryngoscope in our setting.
What is the advantage of that?
It can see hidden areas better, sir. And
so we can do biopsy in the same setting.
Yes, one advantage is that you can do, or you can take biopsy at the same setting. And what are the structures which are not properly visible in your fiber optic examination, which are generally missed while doing a fiber optic examination of laryngopharynx?
Apex of piriform sinus, sir. Postcricoid region.
And any other area?
Postcricoid region.
Okay, one is your postcricoid region, that is your apex of PFS. That is a complete examination of PFS is not possible with your fiber optic laryngopharynx, but if you are using a upper GI endoscope, then with that we can even visualize the PFS apex as well as the postcricoid area. And many a times even you cannot see your a part of the oropharynx also with this your fiber optic, like your tonsillolingual sulcus and other areas.
Okay.
Okay. So after that you did imaging, no? CT scan.
Yes, sir. So contrast enhanced CT scan. Sir, because time acquisition is less for CT scan as compared to MRI. In same sitting, we can do neck and thorax evaluation. We need not to do two investigations, and it's give better thyroid erosion, thyroid cartilage erosion, and good sensitivity, sir.
Which investigation is better to delineate the cartilage and muscle, CT or MRI?
Sir, if
when do you do MRI?
Subtle erosion, in case of subtle erosion of the thyroid, inner lamina of thyroid cartilage, then MRI is one of the decision making investigation. But in advanced disease where gross erosion is seen, CT suffice, sir.
So the main reason is that with MRI it acts as a problem solving tool, that whenever there is your sclerosis of the laryngeal cartilages, this thyroid, cricoid, they are made up of hyaline cartilage. Okay, so with advancing age, that sclerosis can be because of two reasons. One can be because of the tumor, and other can be because of with age related thing also, because of certain inflammation. So as your sclerosis, your cartilage will appear very much thickened, hardened, as well as bright. So to say like whether it is because of the tumor or because of the age-related issue, or there is some minor erosion, then in that case to delineate that thing, we go for CT MRI and we use. But generally for the laryngeal cancer, CECT is the imaging of the choice. And why did you do CT thorax in this case?
Sir, to rule out any distant, because lung is the most common site of distant mets in the CA larynx. So CT thorax, since we are suspecting advanced CA larynx, so we should do to rule out lung mets.
Lung mets. In case of is there any correlation between staging?
Stage 3, stage 4 cancer.
As you have mentioned, the patient.
Stage 3, stage
patient
4.
Patient has not given history of smoking and other thing.
Yes, sir. For distant mets, sir, we are doing CA lung. Because
so it is as a part of your
stage.
Yes. 3. Generally, in case of your advanced diseases, bulky node we do, but like as a part of our institutional protocol also, and to rule out the second primary, which is mainly like present in case of CA larynx patients, generally because the etiological factor is very common, that is your cigarette or bidi smoking. So, ठीक.
So in this image, we can see one necrotic lymph node at the level of level 2. And in this image, there is a bulky bulky growth in the left region of the vocal cord, which destroying cricoarytenoid joint and breaching the thyroid cartilage and reaching to the strap muscles. So after imaging, we can conclude that it's a T4N1. Yes, sir.
Why T4? Sorry, I missed it. Why T4?
Sir, gross erosion of thyroid cartilage and involvement of strap muscles, extralaryngeal disease.
Oh. Okay.
And biopsy of my patient, squamous cell carcinoma grade 2.
Sir is asking why T4?
Yes, a gross cartilage invasion and tumor reaching extralaryngeal spread till strap muscles. Hello?
नहीं हाँ carry on Dr. Kunal.
Okay, Saumyta, go on.
Sir, done, sir.
Okay. So your provisional diagnosis is
Malignant lesion of larynx, not squamous cell carcinoma, sir, histopathology. So CT4N1 disease of CA larynx.
so like how will you manage this case? Like what will be your next modality of treatment in this patient?
So since it is advanced disease and a patient has dysfunctional larynx, then we should prefer surgical procedure.
How do you define that this larynx is a dysfunctional or non-functioning larynx?
Sir, patient had stridor, patient already went for tracheostomy, and patient have intermittent cough on liquid diet, which is a symptom of a dysfunctional larynx.
So Rizul, what are the like 3 criteria to tell a larynx that this is non-functioning larynx?
Sir, one is aspiration, sir. Well, and
Okay.
second is fixation of vocal cord.
Fixation of vocal cord is not given. In case of E3 disease, there can be one vocal cord fixed.
Okay. What are the functions of larynx?
Airway protection, phonation, and speech and swallowing.
Airway protection. So, like there are 3 criteria. If that is fulfilled, then we call it. One is that if there is your dependency on your gastrostomy tube or your nasogastric tube, which in some literature they say that if it is more than 2 years, other is like if there is your permanent this tracheostomy, then we say that this larynx is not functioning because of due to aspiration, because the main function of larynx, as I told, that its main function is to protect the lower airway. If so, like how do you assess this your aspiration is present or not? Is there any your choice of investigation which you will do in this patient to
Sir,
assess
functional
the
endoscopic evaluation of the symptoms, that is FEAS, is a technique in which we are seeing penetration aspiration score, in which we can see
Right.
is aspirating or not, or otherwise simplified 100 ml water test, which we can do in the OPD basis. If patient is having coughing on taking liquid diet, it is also a sign of dysfunctional larynx.
Okay, right, very good. So, like, what you will counsel the patient, whether to go for surgery?
What are the limitations? What are the limitations of FEAS? What are the parameters which you cannot assess on FEAS, and what is the other investigation to complement it?
Sir, video fluoroscopy is the one of the way in which that can also be done for assessing the function. And drawback of FEAS, it is not able to see oral phase of the swallowing. It will be only lower phase of swallowing only we can see, but in fluoroscopy we can see oral phase of swallowing also.
Okay.
So, Saumyta, like in this case, is there involvement of the anterior commissure of the larynx?
Yes, sir.
Why this is significant?
Sir, if anterior commissure is involved, lesion is leaching up to the midline, then we need to address bilateral lymph nodes. And
that is one reason, but why? Why it is important? Why anterior commissure part of? First of all, tell me what are the subsites of supraglottis, glottis, and your hypopharynx? First of all, tell about the supraglottis. What are the subsites of supraglottis?
Sir, epiglottis, aryepiglottic fold, and
Entire epiglottis or part of epiglottis?
laryngeal surface of epiglottis, sir.
Okay,
and aryepiglottic fold,
and
up till false vocal cord.
Up till false vocal cord. Ventricle is the part of what?
Ventricle
Supraglottis or
is
glottis?
glottis, sir.
No. Visual?
Sir, ventricle is part of supraglottis, sir. Sir, parts of supraglottis are epiglottis, aryepiglottic fold, arytenoid, or sir, one is laryngeal aspect of vallecula, sir.
Laryngeal aspect of vallecula? Vallecula? ये तो नया term सुन रहे हैं यार हम.
Sir, मतलब sorry, laryngeal surface of epiglottis, sir.
What are the parts of glottis?
Sir, two vocal cords.
Okay.
1 centimeter below
anterior and posterior commissure.
Anterior and posterior commissure. And 1 centimeter? Just go on.
1
Saumyta,
centimeter
right.
below from the anterior commissure and 0.5 mm below from the posterior commissure or posterior side, sir. That is the
Okay, so
from there
this...
it started subglottis.
Okay, okay. But why this anterior commissure is important? Was it's clinical significance?
Sir, it lacks perichondrium at the attachment of the vocal cord. It's attached with the broil ligament. So, if disease in the anterior commissure has high chances to invade thyroid lamina, and it can go from supraglottis and subglottis in that region.
Okay, so you're very right. That part, no, this anterior commissure is attached with the thyroid cartilage by your this Broyles ligament. Okay, and the point where it attaches, there is lack of perichondrium, so the disease can directly infiltrate into the thyroid cartilage. So even a small disease, which may appear very small clinically, but there can be a subtle or underlying cartilaginous involvement. Okay, so that's why your examination and proper evaluation of anterior commissure is important, and also it's also is indication for doing thyroidectomy also. If there is erosion of that part, then there is very high chance that your thyroid gland might be involved in that disease.
Yes, sir.
Okay, Saumyta, just go on.
Sir, I will counsel the patient about the surgery, and I will explain a patient about the voice rehabilitation options and methods of feeding. Since 14 days patient have to take all food by a Ryle's tube, and followed by I will take my patient for surgery.
So you mentioned that you have taken the decision of surgery.
Yes.
No, you will go for total laryngectomy.
Total laryngectomy with left ipsilateral side, left side hemithyroidectomy, along with bilateral selective node dissection of MND, comprehensive neck dissection on the left side, and selective node dissection on 2 to 4 in right side.
And with
permanent tracheostoma with TP planning, we have primary TP puncture.
So you will give an option of voice conservation or your voice rehabilitation, not voice conservation, voice rehabilitation. So now tell me, had this been a case of T3 disease, then what you would have done?
Sir, in case of T3 disease, there is one University of Florida criteria which says that if functional larynx and the volume of disease less than 3.5 ml, then for such patients, patient can go for organ preservation. But if in case it involves anterior commissure or more than 3.5 ml volume of glottic cancer and more than 6 ml volume of supraglottic cancer and dysfunctional larynx, then it should go for surgical treatment.
Yeah, very right. If this is a dysfunctional larynx, then in that case, you might consider for surgery. And what are the options available if you are not doing a CTRT? Then what are the types of surgeries, types of laryngectomy or the laryngeal preservation surgeries we can go for T3 diseases?
Sir, is a vocal cord is fixed, as in T3 disease vocal cord is usually fixed, and preepiglottic and paraepiglottic space is involved, then the results of partial laryngectomy is not that great, but supracricoid laryngectomy can be option can be done for the patient.
Saumyta, one question. What are the reasons for vocal cord fixation?
Sir, involvement of mass of the tumor itself involves the vocal cord, or precarotenoid joint involvement, and bulky disease, paraglottic space involvement.
So, how do you know whether it is because of mass effects or it is because of the joint involvement? And will it change the outcome of management plan?
Sir, if cricoarytenoid joint is involved, then we should go for surgical option. But if it is due to mass effect, then CTRT also reduce the bulk and patient larynx can be preserved.
So, how would you know whether it is mass effect or is it because of cricoarytenoid joint involvement?
Sir, by imaging.
How would you ascertain an imaging?
Sir, as in this patient, we are able to see that cricoarytenoid unit is covered by the mass.
You can leave this patient. In general, if you encounter a situation where there is mass in the vocal cord reaching towards arytenoid, you are not sure whether the arytenoid joint is involved or not. How would you ascertain whether the reduction in mobility is because of mass effect or is it because of the cricoarytenoid joint? Anyone else? Purvi?
Is there any test to do this?
Test. Not aware, sir.
So we can do direct laryngoscopy to assess whether the cords are mobile or not.
Excellent, very good. So we can, during direct laryngoscopy, we can check for arytenoid mobility.
We can probe that and we can see whether it is mobile or...
But sir, in direct laryngoscopy, when we are doing patient in GA, then how you will assess?
So that is what... Please go on.
Yeah, that is when you have to probe that joint, no? You have to see whether there is if there is some mass effect or if there is that fixation because of arthritis or maybe because of the disease involvement, then that part will maybe not moving. So you have to take a bigger size probe and you can probe that part. So under the direct laryngoscopic examination also, you can see it, and you can also see its position. like in which position your joint is like lying down. If it is because of the mass effect, it would be like pushed, and if there is direct infiltration, that you will be seen also, like while doing the direct laryngoscopic, and like with a probe also you can probe that joint and you can see whether it is fixed or not.
सर जनरल एनेस्थीसिया से इफेक्ट नहीं पड़ेगा, दैट्स व्हाट आई एम आस्किंग. वी आर गिविंग
No,
जीए
as
इन
such नहीं पड़ेगा.
ओके
You want to say कि जनरल से पड़ेगा तो वो रिलैक्स हो जाएगा.
ओके सर.
General anesthesia will relax it. What you are thinking, you are giving an argument against your point. Getting our point, what we are trying to say, Saumyta. GA will relax it. It will be easier to ascertain whether the carotenoid cartilage is fixed or not.
Okay, sir.
So, Saumyta, like as you know that there is a like for the T1, T2 diseases, there is single modality of treatment, है ना?
Yes, sir.
And for T3, T4, we generally go for dual modality. So, why this concept of organ preservation came into force? Can you name some trials?
Sir, veterinarian group of trial of laryngeal cancer is one of the first trial in 1991. They proposed that early laryngeal cancer can be treated with radiation and induction chemo followed by radiation or followed by surgery according to the response assessment, sir. And another RTOG 9111 trial.
Was it for early cancer or for the advanced cancer? Like stage 3 and 4? I think this was for stage 3 and stage 4 cancer. In that, like they went for induction chemotherapy followed by definitive radiotherapy.
Okay, sir. Early cancer, sir, I am not aware.
So, what was the laryngeal preservation rate in that veteran affairs trial?
Sir, in that 56% of the patient can preserve their larynx and 30% of the patient.
64%. Not, it was not 56, it was 64%, if I'm right.
Okay, sir.
Surbhi, कितना percentage था?
64%.
And 30% patient went for salvage laryngectomy, sir.
Okay, like so then like what are the other modalities? Like where in which type of in which stages we can go for laser treatment?
Sir, T1, T2 diseases, usually T1A disease and carcinoma in situ laser modality is preferred, and it should be in mid of the vocal cord or free end of the vocal cord. Then its results are better as compared to RT. And from T1B, if we need to resect, then glottal gap is there after resection of the treatment. So in that condition, RT is preferred over laser.
And in case of your stage 3 cancer, what are the advantage of using CT-RT over surgery?
Sir, if a function...
Why, like which trial has given us the answer that your organ preservation is your modality of choice?
Sir,
is your CT-RT in case of stage 3 cancer?
RTOG 9111 trials.
So, what was the rate of laryngeal preservation in that trial?
Sir, it was for 58% for CT-RT, and induction therapy followed by surgery is 56%, but less than 50% for RT arm. So
that is there. So like CT, how much total larynx was preserved? this trial told us that CTRT is a better modality compared to your induction chemotherapy as well as your adjuvant your radiotherapy or your radiotherapy alone, not adjuvant, your radiotherapy alone. But
55 in long term results, sir, induction chemo followed by surgery have a better survival as compared to CTRT, but it's not statistically significant. And in long term, the cause death from the non-cancer death also more than as compared to. So it means there can be a chances of aspiration pneumonia or subclinical aspiration which is leading to the death.
Yes. You are very right. But when this trial was done, no, it was done around 10-15 years back. At that time, there were not availability of जो हमारे पास आजकल IMRT, IGRT और नए techniques आ गए हैं. So उस समय ना, at that time, the long-term results showed us that in about 80% of the patients, larynx was preserved. 80 to 84% patient larynx was preserved. But you are right. तुम क्या बता रही हो कि like there was aspiration and long term उस समय के patients में देखा गया कि the patients were dying and most of them were because of aspiration. But in nowadays, because of improvement in that your new modality of the IMRT, IGRT, so like there is better quality of life compared to the previous one.
Sir?
Hello?
Yes, sir.
Saumyta. Like do we go for surgery in every case of like stage 4 or T4 disease of larynx, T4A disease of larynx?
Sir, if gross cartilage invasion is there and dysfunctional larynx is there, then we are going for surgical approach. If exolaryngeal disease without breach of the cartilage, in that condition we can go for induction chemo followed by according to response assessment we can decide which modality we should go.
Right. So it has been seen, no, like if there is no cartilage erosion and there is an extralaryngeal spread, involvement of strap muscle, in that case we can give a trial of CTRT is given to see it, because salvage laryngectomy is always an option, and it has been seen because of this new modalities of CTRT and all. And the complication rates are also less, and the quality of life after salvage or the morbidity after salvage laryngectomy is not that bad, which used to be in the earlier days. So in that case, because if there is thyroid cartilage invasion, so in that case there is because it will not respond to the RT because of your vascularity, and there is always a chance of your the chondronecrosis of the cartilage. So in that case, we generally don't prefer that. Can you just name any trial which is specific for hypopharynx?
Sir, EORTC T4 24/9 18.
Surabhi? What was this your EORTC trial?
Sir, in this EORTC trial, CTRT can be done for the hypopharyngeal cancer management, and its CTRT is one of the extrapolation from this VA and RTOG 9111 for hypopharyngeal cancer.
ठीक है. So just do read about this trial. No, this is also known as your. This was a trial, and the authors and all were like this JLA February. So we call it as your JLA February trial. ठीक है, तो इसके बारे में थोड़ा डिटेल पढ़ो, बताओ थोड़ा.
ओके सर.
मे बी आई हैव आल्सो फॉरगॉटन बहुत सारी चीजें इसकी. सो just
sir, one question, sir.
Please.
Sir, if the disease is advanced, T3, T4 disease, that indirectly may indicate that larynx is dysfunction, na, sir?
No, because that may not. Because your T3, how do you define it as a T3 disease?
If it is advanced, T3 is the fixed vocal cords in case of glottic cancers.
Not only fixed vocal cord, it can be because of the involvement of the pre-epiglottic space or paraglottic space. So, मतलब of course your stage 3 and stage 4 are called as your advanced diseases only. Stage 1 and 2 are your early diseases. So in that case, of course, earlier there used to be a fight because people say that your this pre-epiglottic and para-epiglottic has a lot of areolar tissue and fat. So, and if there is a tumor volume, as Saumyta mentioned, that more than 3.5, no, Saumyta? 3.5 cc.
3.5 cc for glottic cancer and 6 cc for supraglottic cancer.
So there are chances of like curing with it is less. But that used to be in the earlier days. Nowadays, with a new modality, because there is a lot of development in your RT arm also. So we can directly like focus on the disease part. And so our protocol is to preserve the larynx because biggest trials it has shown with that also like as your RTOG trial tells us that there is chance of 88 or to 80% of preservation of larynx. So generally we go for this CTRT, and if there is a recurrence or if there is a residual, then salvage laryngectomy is an option for us. So Saumyta, इसमें you mentioned about this TEP, no?
Yes, sir.
So how do we do this TEP?
Sir,
what are the types of TEP?
Bloom-Singer prosthesis and duckbill prosthesis are the two types of tracheoesophageal puncture prosthesis.
No, first I asked you, what are the types of TEP, tracheoesophageal puncture? One is your primary, other is secondary.
Yes, sir. So primary we usually prefer in the upfront. If we are taking patient for upfront surgery, then primary TEP is preferred, and in salvage setting, secondary TEP is preferred. This is due to the chances of pharyngocutaneous fistula, that leak is more in the salvage setting as compared to upfront setting.
So one thing you mentioned that, and other thing is like if you are putting some kind of flap over the your neopharynx area, and if you are putting especially like jejunum flap, free jejunal flap, then in that case generally primary TEP doesn't work that well. So in those cases, we can go for subsequent
secondary
TEP or secondary TEP. So what is this mechanism of your TEP? How does this work?
So due to vibration of that pharyngeal cricomyotomy we are doing, and there is a vibratory movement of that wall.
Why do we do this cricomyotomy or pharyngeal myotomy? Which muscle is cut there?
Cricopharyngeus, sir.
cricopharyngeus muscle, which is a part of which muscle? Is part of inferior
Intrinsic.
constrictor.
हाँ.
ठीक है. It has got two parts. One is your thyropharyngeus, other is your this cricopharyngeus. And why do we do this?
Sir, it gives the vibratory motion to support TEP.
So, like how a speech is produced?
Esophageal.
There's a source, there's a vibrator.
Lung air produces this.
Yes. So like there are three components. One is a source, that is your vibrator, and third is your resonator, which resonates. Okay. So the vocal cord acts just as a vibrator. The air comes below the vocal cord through the lung, and then it vibrates, and then that is it articulated by your articulators like tongue, soft palate, hard palate, and other things. So the main function. So how does it differ from esophageal voice?
In esophageal voice, sir, that main source of air is coming from the esophagus, not from the lung.
Not from the lung. So how it is different?
So it's very learning curve is very difficult, and
one is your learning curve, as you mentioned, no, and that there is different in the source. So there is difference in the volume of the air.
Yes, sir.
As in case of esophageal voice, it will be around 30 to 40 ml only, because you have to swallow the air at the, and then like while expelling it out, you have to try to speak. So one is there is change in the volume of the air, that is just 30 to 40 ml. But in case of your this TP, once you do, so there is no deficiency of air. It is as equal to 400 to 450 ml, जितना tidal volume हमारा होता है. So that is the where the main difference lies. And secondly, there is long learning curve, and failure rate is very high. That is around 40 to 50% in case of esophageal voice.
Speech.
In case of the esophageal voice. Okay. So just tell me, like you have done a laryngectomy, okay?
Yes.
So when do you put, or what should be the minimum your breadth of the remaining pharyngeal mucosa to close it primarily?
3 centimeter unstretched mucosa at the narrowest part of the closure.
Yes, 3 centimeter unstretched and 5 to 6 centimeter stretched mucosa. It should be there. And what are the types of flap which you can use there to create a new pharynx?
If patient, we are constructing only posterior wall, then we can use free flap also, and PMMC also. And if we are doing in salvage setting where we are doing primary closure, in that we can overlay PMF flap also, and supraclavicular flap can also be used, sir.
Yes, you're very right. So there is two conditions. We can, when we use PMMF, that is a pectoralis major myofascial flap, that is not to create or to make a neopharynx. That just helps as a extra layer of closure. So
Yes,
study, like where studies are going on, which has shown that if you put it, there might be decrease in the rate of your leak.
If in case leak, the leak rate is not differ, but hospital stay is
there is
hospital
there is an ongoing trial in Tata which is going on. So like long-term result has to come, and you are very right. There is not much difference in the leak rate. And third, like if you have to create the new pharynx, then in that case, like you can use this PMMC flap, you have to tube it. You can use the supraclavicular flap. You can use this island nasolabial flap. Even you can use this jejunal free flap. But what is the disadvantage of, or what is the limiting factor of using jejunal free flap?
So microvascular help is required. We have to explore abdomen also, and voice is also difficult to achieve voice outcome.
Yeah, you're very right. And the one biggest disadvantage is that the ischemia time of jejunal free flap, that is not as great as in our other conventional free flap which we use. Ischemia time कितना होता है इसका?
No, not aware, sir.
Sikha is there or no? Rizul? I'm not very sure, but I think it is less than or maybe 30 minutes. Not very sure. You can like see in the literature, but it is. Okay. Now, like if you have done a laryngectomy, and what are the factors which determine or which will tell you that there might be an impending leak, and you should be careful. Like,
sir, any redness or local inflammation, patient is having fever, spike, tachycardia.
Okay, very right.
Or duration of such leak is also play an important part. Is less than 2 days or more than 6 days.
So these are the important prognostic factors which you mentioned regarding the pharyngocutaneous leak. If this leak has occurred, how do you manage it?
Sir, if less than 2 days if less than 2 days post-op and a patient is having leak, then we can go for according to the drain amount of drain patient is having features, we can go for re-exploration. But if more than 6 days, then we should prefer conservative modality of treatment rather than re-exploration.
Right. And Saumyta, you also mentioned about hemithyroidectomy, Anna?
Yes, sir.
So, like in which condition or like in which cases we go for hemi, and in which cases we can go for total thyroidectomy, or is there any study to tell that we should not go for thyroidectomy only? What are the disadvantages
I am not aware, but chances of thyroid involvement in CA larynx, if it's stage 4, then it's 14% are the incidence of 14% the incidence of involving thyroid gland. So
it is around 8 to 14%, yes, or 8 to 12%. Some literature says. Okay.
So people, there are two schools of thought. Some people say ki we can avoid thyroidectomy, but some people say it's better to remove ipsilateral thyroidectomy in the same setting because readdress of that area is not feasible in future.
Yes, you are right. So one is there if there is your thyroid cartilage erosion, then in that case we should go, although it is not necessary that in every case of thyroid cartilage erosion there will be involvement of thyroid gland also. There are two schools of thoughts, as you very well mentioned. Secondly, if there is your subglottic disease and anterior commissure involvement, and then in that cases there are very high risk of
level 6 involvement, sir.
Involving thyroid. Yes, right, level 6 involvement. And once there is subglottic, there is high chance that your cricoid cartilage will be also involved, and disease can spread through the cricothyroid membrane and So for your proper clearance of level 6, also you need to do a thyroidectomy. But generally, yes, and because that will help you in a proper clearance of the level 6. So generally, we avoid total thyroidectomy, but if there is bilateral thyroid cartilage involvement and there is your lymph node involvement of at the level 6 and cricoid cartilage involvement, then in those cases, we might think of doing total thyroidectomy also. But that situation is very rare. Generally, we go for ipsilateral thyroidectomy only. So now, just you tell me about one last question. Like, why don't we nowadays your partial laryngectomies are very common nowadays?
Sir, because CTRT, there is a comparison of CTRT versus partial laryngectomy, and post partial laryngectomy, there is subclinical aspiration and voice results are not great as compared to organ preservation protocol. That's why it's increasing post-op morbidity of the patient.
Yes. So one is because of this quality of life, and secondly, your partial laryngectomy is very much your surgeon dependent also. Yes, expertise you need. There is high chance of aspiration, and for that also you need to have a good pulmonary function. If there is a bad or poor pulmonary function, then that in such cases partial laryngectomy doesn't work well. हाँ वही है. So ठीक है, अच्छा presentation किया है. And next किसका है?
सुरभि का है सर.
Surgery versus RT. What is difference in the quality of life? मतलब your quality of voice. Where you go for laser, where not to go for laser, वो सब थोड़ा पढ़ना. About laser also. हाँ? मतलब उसके लिए कोई ट्रायल चल रहा है या क्या स्टडी है, then your use of robot या फिर Japan and Korean countries में they are using your मतलब endolaryngeal surgeries using endoscopic procedures also उससे कर रहे हैं. तो all these recent advancements और हमारा organ preservation protocol.
Okay, sir.
That is more important thing, because if you don't read it frequently, you will forget क्या उसका क्या data था क्या था, and the examiner might ask about these trials and all. वो सब पूछ सकते हैं. So just read all these things in detail, है ना?
Okay,
और हमें बताओ फिर. We
Yes.
can हम लोग एक रख सकते हैं एक class, maybe next seminar on this with organ preservation protocol in larynx and hypopharynx. And in that हुआ तो नहीं है ना, या हो गया इस पे सुरभि?
नहीं हुआ सर अभी.
अब नहीं हुआ है ना? So we can discuss. Then on that day we will be talking in detail. आज we could not discuss, है ना, बहुत ज़्यादा. But maybe in the you people also read and I will also read, है ना?
हाँ.
ठीक. Okay.
Thank you,
चलो,
sir.
all the best.
Thank you, sir.
Thank you.